So Hutch is going to be speaking to us today about acute management of traumatic brain injury, and I'll now hand over to him to speak.
And thank you for the invitation to speak. Thanks to Andy and Tom for the invitation, all the help with the arrangements. So my remit is to talk about traumatic brain injury, predominantly focusing on the acute aspects of this condition. So as you know, head and traumatic brain injury is a journey for a patient from the scene of an incident, be it RTA, falls, assaults and sporting injuries, through emergency medicine care. Some patients with severe injuries require surgery. Patients with severe injuries also require intensive care. And then the ultimate goal is to get them through a successful rehabilitation program and reintegration into the community. Head injury is common. There's about 1 million attendances to emergency departments in the UK per year, and it is the highest cause of mortality under the age of 40. And as you are all aware, it's a major cause of morbidity in survivors. So we've done a global study. Interestingly, we focus very much on the UK. Only 10% of head injuries occur in high-income countries. About 11,000 people die every day from trauma on the planet. Many of those die from head injuries, and this is now a pandemic in many countries in the world. You can see the mechanism of injury is changing. So the commonest mechanism of head injury now in the UK is a fall, particularly in elderly patients. But in many parts of the world, road traffic collisions are becoming an increasing problem, as sadly are assaults. So head injury has a long history. We've known about it for thousands of years. There were attempts at early trephination in that skull there on the left. Interestingly, that patient showed healing at the bone margin, so survived the neurosurgical procedure. And then as you advance through centuries, you get through to Hippocrates, bizarre instruments to raise depressed skull fractures. And then moving into the last century, one of the major advances is that of prevention, with motorcycle helmets. A lot of the technology that's come through motorsport and car design, seatbelt design, has now percolated through to road traffic collisions in terms of civilians. And then there's been some recent parliamentary advances, including the All-Parliamentary Group and the recent acquired brain injury bill that's being led by Chris Bryant. So I'm going to talk about 5 main areas: epidemiology documentation, the initial management, some of the aspects of what we do in neurosurgery and ITU, some of the way we gain evidence through clinical trials, a bit about the post-acute management, and then a conclusion and discussion. So as I said, head injury is common. It needs to be distinguished from traumatic brain injury because you can, of course, have a head injury without a traumatic brain injury in terms of facial injuries. But overall, these are common. Large numbers of patients, 1,500 per 100,000 of the population, attend per year. About a fifth of those are admitted to hospital. The number actually getting to neurosurgery, so the more severe ones, is relatively smaller, but there is still a significant mortality. And if you look at the number of disabled survivors, as you're aware, that it runs into the several millions. How do we classify traumatic brain injury? So there's 3 ways you can do that. The first is by the mechanism, and the mechanism is quite straightforward. It can be closed and it can be open. And a closed injury is a high velocity, typically road traffic collision, or low velocity falls and assaults. And that is by far the commonest injury that we see in the UK. In other parts of the world, open injuries are common in terms of gunshot wounds and other penetrating injuries, but sadly we are seeing increasing penetrating injuries from knives in certain parts of the UK at the moment. So that's the mechanism. The second is the severity, and I'm sure many of you will be familiar with this. There's something called the Glasgow Coma Score, and that is a scale from 3 to 15 and defines the severity of injury in terms of level of consciousness. And the best you can be is a GCS of 15 when you're alert and orientated, and 13 to 15 is defined as a mild injury, 9 to 12 is moderate, and 8 or less is severe. And that has a word, GCS 8 or less is called coma. And then the third way you can classify it is in terms of the morphology or the anatomy. So you can look at the skull and the pattern of skull fractures, which can be the vault, the top of the skull or the base of the skull. And then, of course, importantly, beyond the skull fracture is what goes on inside the head with what we call either a focal injury, usually a hematoma, or a diffuse injury. So in neurosurgical terms, there are two main types of injuries. There's a hematoma. This is something that requires neurosurgery to evacuate it, compared to a diffuse brain injury where there isn't a mass lesion, there isn't a blood clot for us to remove surgically. But nevertheless, these patients can have quite severe injuries. The mildest form of diffuse brain injury is concussion, which can occur without loss of consciousness, but it's still like a diffuse brain injury. And the most severe form of diffuse brain injury is this diffuse axonal injury, where patients can remain in a persistent coma and vegetative state. So there was a big revolution in terms of the initial management of these patients over the last few years. Historically, patients used to be taken from the scene to the nearest hospital, which may not have the best capability. So the major trauma centre network was established. It started off in London, was one of the sort of prime drivers for this. And the aim is to get somebody to a major trauma centre which has all the specialties that you need to treat trauma in a very time-efficient manner. So the deal is for the major trauma centre network, if you are within 45 to 60 minutes of a major trauma centre, you will be taken straight to that major trauma centre. And that will often involve bypassing smaller hospitals. Now, London is interesting because major trauma now is focused in 4 hospitals, but everybody in London is within this time window of these 4 hospitals, and they're St Mary's, Royal London, King's and St George's. They're in the 4 quadrants. So where I work in Cambridge, at Addenbrooke's Hospital, we have challenges because the geography of the region doesn't allow that. But you can see that hospitals near us would be bypassed, would come straight to Addenbrooke's, but those in the white areas may be stabilised initially in the district hospitals, such as Norfolk and Norwich, and then undergo a secondary transfer. Having said that, with the air ambulance, we're getting more patients in directly. The management of the severely injured patients is according to various protocols, and the commonest that's in use now is the Advanced Trauma Life Support Protocol. This came out of the US, and it's a very stringent way by which you manage the patients according to their primary survey, controlling their airway, checking their breathing, maintaining their circulation, and assessing their neurological disability. What's really important for the head injured patient is to maintain a good oxygenation of the blood and a good blood pressure. So this is where breathing and circulation are paramount, as well as assessment, resuscitation, oxygenation, ventilation, fluids, and then a secondary survey where we examine the patient in more detail. One of the issues that we face is that if there's 1 million patients coming a year to emergency departments, the gold standard for investigating these patients is the CT scan. We cannot logistically CT everybody who comes with a head injury. So NICE have looked at some of the criteria that will predict deterioration from an evolving mass lesion. So this is the prescription, if you like, of patients who come to an emergency department who will be selected for CT imaging of the head. So you have to have some of these risk factors. Glasgow Coma score of less than 13, so a moderate injury at any point. If it's 13 or 14 at 2 hours after the injury, if you suspect an open skull fracture, that's when the scalp is open and lacerated, or a depressed skull fracture where part of the skull is driven in towards the brain. Basal skull fractures, if you've had a seizure, if you've had a focal neurological deficit, so a weakness or speech disturbance, more than one episode of vomiting, or retrograde amnesia of greater than 30 minutes. So these are the criteria for a CT. Also, there are some others, and this is more recent: age greater than or equal to 65 years, and coagulopathy. So this business now of the commonest cause of head injury in the UK is falls in the elderly, they're on anticoagulants, warfarin or a similar agent, or antiplatelets such as aspirin, and they are prone to bleeding which can expand, and finally a dangerous mechanism of injury. So these are some of the pathologies that you may see on a CT scan. This is an extradural hematoma. So this is a blood clot between the skull and the outer membrane, the dura. It's usually arterial bleeding. These patients are often knocked unconscious. They recover, and then as the hematoma expands, they become unconscious again. That's called the lucid interval. Generally, these patients have a good prognosis because, strictly speaking, this isn't a primary brain injury. It's a blood clot between the skull and the dura around the brain. They're actually relatively rare. These are common acute subdural hematomas. This is the commonest mass lesion that we see, often in elderly patients. They are usually bleeding from veins, and you can see this patient with this big hematoma there on the left causing considerable shift of the brain over to the right. And then you can have bleeding in the brain itself, so that is what we call a contusion in the left frontal region, and that is a mixture of blood and bruised brain. This can be direct under the site of impact, or what we call contre-coup, where you hit one part of the head and the brain is then displaced against the inside of the skull, usually diametrically opposite, and that is called a contre-coup injury. So these are the mass lesions that I talked about, but what we commonly see is there isn't a blood clot. These patients don't need to go for an operation to remove the blood clot, but the brain is diffusely swollen, and this is this condition of diffuse axonal injury. And these patients, there's no surgical target, so these patients tend to be managed with medical treatment in the first instance. So although CT scans are the gold standard for imaging, they can miss some quite important prognosis-defining pathology. So this is a patient of ours in Cambridge. He wasn't wearing a cycle helmet. He gets knocked off his bicycle, and he has this, the pointer's working. This is an extradural hematoma, which is shown here, and that's what everybody focused on. The junior surgeons loved it because they can do an operation. They love doing operations, so off they go and do their operation. What people didn't really notice was this contre-coup contusion of the brain. You see that on the right? That's quite subtle. But when you do the PET scan, this is a blood flow scan, there's a hole, no blood flow here. And when you do an MRI scan, which is a much more sophisticated and subtle scan at 6 months, you see an area in the frontal lobe here of gliosis, which is not on the CT scan. And this patient, as Ruth was saying about frontal lobe pathology, had a lot of problems with cognition, personality change and behavior change that was very disruptive, and actually their life fell apart. So although surgically this is relatively straightforward, you have to be conscious that you need to look for these other areas of brain injury. About 25% of people who have a normal CT scan, if you actually do an MRI scan, you will pick up pathology. So an MRI scan is actually quite an important investigation. So what about the neurosurgical and intensive care management? The problem that these patients face is that when you bang the head, the brain swells. It is swelling in the tight box, the skull. The consequence of that is the pressure goes up. When the pressure goes up within the head, there is a reduction in cerebral blood flow, a failure of oxygenation of the brain, energy failure, and this more swelling and this vicious cycle. So the goal of our treatment is to try and control the pressure within the head, and that's called the intracranial pressure, the ICP. So we can measure ICP by putting a bolt and a small pressure transducer actually into the brain itself, and the normal intracranial pressure, BUMI at the moment, is around 10 millimeters of mercury. Above 20 is defined as abnormal, and above 40 is severely abnormal. And we've done a lot of studies that show when the pressure is high, the outcome for the patient is worse. So the goal of treatment is to control pressure. Who gets a pressure monitor? So we ran this consensus conference in Milan, and if you come in coma, so your GCS is 8 or less, and you have a normal CT. Generally, we don't advocate ICP monitoring, but if the scan is in any way abnormal and you're comatose, then we would take the patient to intensive care, put them on a ventilator, and put one of these pressure monitoring devices in through the skull. And then we developed the software to measure pressure, so you can see the white graph there. That is the brain pressure of a patient on the intensive care unit over several days of monitoring, and you can see how the brain pressure varies with time. At some points it's relatively normal, around 10 millimeters of mercury, but up here we're spiking up to 40 and 50. And we measure this now routinely in all our patients. When the pressure is high, we try and control it using a combination of simple conservative measures, drug therapy, and potentially some surgical maneuvers. And that would include nursing patients head up. We can put a tube, a drain, in through the skull into the ventricles in the center of the brain-to-brain fluid. We can cool the patients, and then there's various drugs of sedation. If the brain pressure is high and you increase the blood pressure, you will encourage blood into the brain and improve blood flow. This is the sophisticated algorithm that we use, and these are our targets. So we need to keep the intracranial pressure less than 25. We do this through all these therapies that you don't need to worry about in terms of the detail, but what's a particular challenge for us is that despite a lot of these interventions, the brain pressure still remains above 25, despite everything that we're doing. And these patients, as particular interest of mine, they're the most challenging to treat. And we, at this stage 5, when everything else has failed, there are some options of putting them to a really deep coma called a barbiturate coma, or this operation, decompressive craniectomy. And I'll come back to that. What's important is to be able to measure the pressure, which is what we do routinely, but we now have new technology where we can actually measure how much oxygen there is in the brain and how much energy there is in the brain. And that is through this cranial access device. So this is something that we developed as a research technique, but it's now used routine NHS practice. It is a device that goes through the skull and it transmits 3 probes into the brain. There's a pressure probe, there's an oxygen probe, and a chemistry probe. So there's the oxygen probe, and we put in this chemistry probe as well. So we can now measure the pressure in the head, the oxygen in the head, how much glucose the brain is getting, and how the brain uses that glucose to generate energy. But beyond that, what about surgery itself? So the role of neurosurgery is acute surgical lesions, so the hematomas that I showed on the scans earlier. But there's quite a lot of interest now in neurosurgery itself for when the pressure is high with diffuse injury and no focal blood clot. So we can operate for hematomas, as I said, the extradurals, the subdurals, and the intracerebrals. Common indication for surgery, not so much in this country, but in global partners, is depressed skull fractures. A common injury in Africa is falling asleep under the coconut tree. Everybody laughs at this, but it's quite common. Coconut comes down, depressed skull fracture. Let's see an awful lot of that in Africa. Our operative intervention for diffuse brain injury is also possible. We can drain CSF through a ventricular drain, and we can potentially remove parts of the brain, but this operation, decompressive craniectomy, is an option. What is a decompressive craniectomy? If the brain is swollen, the pressure's high inside the skull, one way to control that swelling is to remove a big part of the skull. It's simple in concept. You take a large piece of skull away, and then you put the scalp back over the brain, and you discard the bone, or you can keep the bone and replace the bone later at some point. So that's called a decompressive craniectomy. Our approach to this operation is we remove the frontal bone on both sides, and then later down the line you need to reconstruct the skull. So once the swelling's settled, you can put the skull back together again, and the options are to put the patient's own bone back. You can either store the bone in the freezer, or you can put the bone in the patient's abdomen. Some people do that. It keeps the bone clean. I'm not a great fan of it because I think the bone gets resorbed. So our practice now is not to put the patient's own bone back, but to use some form of synthetic bone replacement, either acrylic or titanium, or that's a peak polyether ketone. But the timing and material of skull reconstruction is quite controversial. Then we see other things. This is a self-inflicted injury from a crossbow. This was one of my patients, and the big challenge, we had a huge debate as to whether to take this out from below or whether to continue to take it through from above. But this patient, despite that injury, actually had a remarkable recovery. There were no major structures damaged from it. You can see this is what's called a CTA. So this is a CT angiogram. You can see the bolt here, but actually it has spared the major blood vessels. So occasionally we get some quite interesting and challenging cases. What I want to talk about now is a lot of what we do. We're trying to work out, is it the right thing, or should we be doing things differently? And the way we're trying to do that is through these clinical trials in traumatic brain injury, where we're looking at medical and surgical interventions to get the evidence to see how we can improve treatment. So the medical interventions, there's been many, many drugs that have been tried for traumatic brain injury. So the patient comes in on intensive care, on a ventilator, and these are what we call the so-called neuroprotective drugs. They've worked in animal studies, but when they've been tried in patients, they've been universally disappointing. And none of these therapies has actually shown a change and improvement in outcome in severe traumatic brain injury. So really we've abandoned this sort of approach of novel therapy at the moment in terms of drugs, and we're tending to focus a lot more on the surgical trials. And I just want to talk about one trial that we ran on decompressive craniectomy. So decompressive craniectomy, as I said, is removal of a large piece of the bone, and that can be done in two ways. You take out this subdural hematoma. If the brain is swollen, there is the option to leave the bone out at the end of that operation. Normally we put the bone back, but you can leave the bone out. But in the patients with the diffuse injury, as I said, one option is to remove a large bone flap to control pressure. And that operation had been around for several decades, but we were unclear as to whether it was the right thing to do. So firstly, does it reduce pressure? Secondly, does it save life? And thirdly, what is the quality of that life saved? The surgery itself, so this is a unilateral decompression for an acute subdural. So you can see classically we have to do quite big surgery. That's a large question mark flap. And this is the bifrontal decompressive craniectomy, where we're removing the frontal bone right back to the top of the head down to the just above the orbit. So it is quite major surgery in terms of the bone removal. So we got a number of colleagues together internationally to try and answer this question about this decompressive craniectomy. Is it the right thing to do? Does it improve outcome for patients? So the hypothesis for the trial was that decompressive craniectomy can improve outcome as a last tier therapy. What do I mean by that? You've tried all the simple things to control pressure. Pressure's still really high. So there is the option then to perform this operation to remove a large piece of the bone. So we took patients on the intensive care unit on a ventilator with a pressure monitor, pressure's above 25, and then we, after consent, clearly you can't take that from them, but from family, we randomized them into this advanced drug treatment, barbiturates, versus a decompressive craniectomy. And then we looked at their outcome at these various time points. I don't know how many of you heard of this. Is the extended Glasgow outcome scale. So there's the Glasgow coma score, which is the level of the severity of injury, but then a lot of people assess their outcome by what's called the extended Glasgow outcome scale. And this is bandied about a lot. People talk about it a lot, but it's really, really important to understand what this actually means. It's an 8-point scale, and the extremes are easy. There's mortality at one end, upper good recovery is back to no injury-related problems at the other. But these intermediate states can be quite confusing. The vegetative state, I think people are clear about. That is somebody who's unable to obey commands. But in terms of severe disability, you can be dependent on others for care. That's called lower severe disability. But upper severe disability, you are independent at home for at least 8 hours. And then you go through lower moderate and upper moderate, where you begin to become more independent outside the home. So it's important to understand what these categories mean. So we went off, and took us several years to recruit these patients. We randomized just over 400. It was a big international effort, mainly UK, and this was the results. What it showed was, on the top there you have the surgical patients, and in the bottom you have the medical patients. There was a marked reduction in mortality. There was no doubt that this operation was saving life. You can see the mortality went from about just under 50% to 25% with surgery. But the concern was the spectrum of quality of life and disability in the survivors. So although surgery saved life, you had to accept, while some of the patients were doing well in terms of moderate disability, it did increase the numbers of patients in the vegetative state and lower severe disability, and that's more easily digested on this slide, where we're now at 12 months. Again, you can see in black the difference in mortality, in red the difference in vegetative state and lower severe disability. But at about 12 months, and this continues to get better after 24 months, is the number of patients in the surgical group getting into the better outcome category has increased. So we now use this data to try and help guide decision making. If you undertake a decompressive craniectomy, for every 100 patients you do that on, you save 22 more patients, but you have to accept 5 of them will be vegetative, 4 lower severe disability, and 13 will be upper severe disability or better. So about 60% are reaching a degree of independence. The problem, of course, is that there is no doubt that this operation is good for some people, but not good for others. How do we try and improve patient selection? CT is fantastic as the first-line imaging. It shows blood clots. But what it doesn't do is pick up some really important lesions. So the brainstem, which is shown here, is the critical part of the brain where everything is communicated from the brain down to the spinal cord. If the brainstem is severely injured, it's like a really high spinal cord injury. The patient will have a very bad outcome. So decompressing the top part of the head and the cerebral hemispheres in somebody who's got a brainstem lesion is probably not the right thing to do. So we need to get a bit smarter and avoid decompressing these patients. And the same applies to really bad diffuse axonal injury. This brain is so severely injured as part of the primary injury that actually decompression, craniectomy for high pressure again is probably not in this patient's interests. What's interesting, what I've learned is that we used to talk about these studies being positive or negative, outcome is favourable or unfavourable, but I'll have a patient in clinic who'll come in a wheelchair, dysphasic, but actually they're quite happy. They're grateful to be alive. They've got a really supportive family, and they were pleased we went down this route. And the next patient is miserable because their scar is numb, despite the fact that they're back at work. And you've seen this before, that patients' perceptions of their quality of life is not always consistent with the healthcare professionals. Finally, I just want to touch a little bit on what Ruth was saying. It's really important, following this period of intensive care, that we make sure that patients have very good access to rehabilitation. So we've mapped the hospitals in the Eastern region, and you can see the deficiency in the neurorehabilitation services. There is still impaired access, particularly to what we call rapid access rehabilitation, to take the patients on the next stage of their journey. Having said that, we've established this specialist neurotrauma clinic. So this is an NHS clinic, neurosurgery, rehabilitation, neuropsychology and headway. We do a ward round with our neurorehabilitation consultant on the intensive care unit, and we follow up patients into the longer term, looking at their rehab needs, the issues regarding skull reconstruction, epilepsy. I'll just touch very briefly on home circumstances, employment and driving. One of the issues, as you know, in medical legal practice is this business about predicting who's going to have a post-traumatic seizure. This is really important in terms of implications for driving and employment, particularly bus and lorry drivers, because their risk must be less than 2% per annum. So there is some data in the literature. This ANIGA's data suggests a 10% a risk at 5 years. The Christiansen data, perhaps a 2% risk at about 6 months. The problem is that these studies are very coarse. They categorize scans as normal or abnormal, but this patient with a tiny little bit of blood here probably doesn't have the same risk of seizure as somebody with these multiple contusions. So we're also embarking on a study to try and refine the prediction of post-traumatic seizure risk. So to conclude, there has been advances through a number of initiatives, the British Neurotrauma Group, the Trauma Audit Research Network, the major trauma networks, and by that I mean pre-hospital care through to rehabilitation, some of the guidelines. And the mortality of head injury in this country has really fallen over the past couple of decades. And for many of the patients, their quality of survival is good, but what I think we need to focus more on is just trying to get those patients in the lower severe disability states better. To conclude, as I said, one of the real initiatives that we're trying to address now is the gains probably in the UK are relatively small in neurosurgical terms, but where we can make a difference is if we go out into the lower middle income countries. So the work we're doing in Africa and India with motorcycle helmet legislation, trying to get people to hospital in an appropriate vehicle. We went out to Zambia to see if we could do a trial of decompressive craniectomy. They said, well, that's a very fancy protocol, Professor Hutchinson, but actually, could you please bring a drill? So this is what we used in the 1800s. This is what they're using now. So we took one of these out. It's amazing that that these things are going on. This is good. This is the infrascanner. So that's a handheld scanner that can detect hematomas when CT is not available, and that is a handheld ultrasound. Cheap because there's no display, you just connect it into your smartphone. So to finish, I'd just like to thank many of my colleagues in Cambridge and beyond involved in our clinical and research studies. These were the PhD students that we had a few years ago. They've all grown up and become consultants now, so I guess that's good. Thank you very much for your attention.